Hi everybody, myself Dr. Ramesh, Medical Director, Dr. May, Super Specialty, Eye and Research Center, Silver, Ludhiana, Punjab, India. I am introducing myself that we are working for the promotion of the eye nutrition movement in Punjab from last 28 years successfully, running health education drive, especially for eye health and general health for public awareness point of view. Our hospital, Dr. May's Super Specialty Eye Care Center, is fully NABH accredited eye care organization from 2018. And we are taking our eye patients care with international standards and guidelines. So as a part of responsibility today, we will discuss in detail about current topic, that is the giant corona. Today we will discuss how we can prevent ourselves and take care of our esteemed eye patients from coronavirus infections. We are sharing the important ophthalmology specific information related to the novel coronavirus, referred to as the severe acute respiratory syndrome coronavirus 2 SARS-CoV-2, which is previously known by the provisional name as 2019 NOC, the highly contagious virus that causes the severe respiratory disease known as COVID-19. That's what you need to know. Several reports suggest the virus can cause conjunctivitis and possibly transmitted by the aerosol contacts with the conjunctiva. Patients who present with the ophthalmologist for conjunctivitis who also have the fever, respiratory symptoms including cough, shortness of breath, and who have recently traveled internationally, particularly those areas which are known for the outbreaks such as China, Iran, Italy, such. So we should take care of those patients. So as a eye specialist, we recommend protection for the mouth, nose and eyes when caring for the patient potentially infected with the SARS-CoV-2. The virus that causes COVID-19 is very likely suspected to the same alcohol and bleach-based disinfectant that ophthalmologists commonly use to disinfect the ophthalmic instruments and office furniture. To prevent SARS-CoV-2 transmission, the same disinfection practice already used to prevent the office-based spread of the other viral pathogens as recommended before and after every patient encounter. Let's see, we have a small background of this coronavirus. The SARS-CoV-2 is an enveloped single-stranded RNA virus that causes COVID-19. Although the virus appears not quite as likely to cause the fatality as the SRS coronavirus or MERS coronavirus, a significant number of the global fatalities have already occurred. Patients typically present with the respiratory illness, including fever, cough, and shortness of breath. Diarrhea is common early in the infection, and conjunctivitis has also been reported. Severe complications including pneumonia. Symptoms can appear as soon as 2 days or as long as 14 days after the exposures. In March 10th study in the Annals of the Internal Medicine found that the mean incubation periods for the SARS-CoV-2 was 5 to 7 days. More than 97% of those who developed the symptoms did so within the 11th day of the exposures, finding that further support the current 14 days of the quarantine is recommended. So now we will discuss the current understanding. Current understanding about the how COVID-19 spread is based largely on the what is known about other similar coronavirus. The virus is believed to be spread primarily by the person to person through respiratory droplets produced when an infected person cough or sneeze. It also could be spread if people touch the object or surface with the virus present from infected person and then touch their mouth and nose and eyes. Currently thinking that the SARS-CoV-2 can be spread by the asymptomatic transmissions. So very interestingly, the Dr. Li Weilang, MD from the China, who is a whistleblower ophthalmologist who sounded the initial alarm on the coronavirus. believed that he was infected by the asymptomatic glaucoma patients. The reports, however, remains still preliminary. Two reports suggest that the virus can cause the conjunctivitis. Thus, it is possible that SARS-CoV-2 is transmitted by aerosol contacts with the conjunctiva. In Journal of Medical Virology study of only 30 patients hospitalized with COVID-19 in China, one had conjunctivitis. That patient and not the other 29 had the SARS-CoV-2 in their ocular secretions. This suggests that SARS-CoV-2 can infect the conjunctiva and cause the conjunctivitis, and virus particles are present in the ocular secretions also. In larger study published in the New England Journal of Medicine, researchers documented conjunctival congestion in 9 out of 1,099 patients, approximately 0.8%, with the laboratory confirmed COVID-19 from the 30 hospitals across the China. While it appears conjunctivitis is an uncommon event as it relates to the COVID-19, and other forms of the conjunctivitis are common. Affected patients frequently present to eye clinic or emergency departments that increase the likelihood of the ophthalmologist may be the first provider to evaluate the patient possibly infected with the COVID-19. I have some questions you should ask to identify patients with possible exposure to SARS-CoV-2 infections. Number 1. Does your patient have any fever or respiratory symptoms? Has your patient or their family member traveled recently? Red flag include the international travel to countries such as China, Iran, Europe and South Korea and some part of the USA and Canada also. In response to the as an emergency, so most of our clinicians, eye care professionals, ophthalmologists, they should postpone those outpatient visits and the procedures that can be safely delayed, and particularly in elderly patients and those with the morbidities. The appointment of the patients with the non-urgent ophthalmic problems. Second, if our hospital or our clinic permits, the patients who come for the appointment should be asked prior to entering the waiting area about the respiratory illness and whether they or their family members have traveled to high risk area in the past 14 days. If they answer yes to either of the questions, they should be sent home and told to speak to their primary health physicians. Waiting room as empty as possible. Advise the seated patient to remain at least 6 feet from one another. As much as prudent, reduce the visit of the most vulnerable patients. If the patient with the known COVID-19 infection need urgent ophthalmic care, they should be sent to the hospital or center equipped to deal with the COVID-19 and urgent eye conditions, ideally in a hospital setting under the hospital infection control conditions. The use of the commercial available slit lamp barriers or the breath shield is encouraged, as they may provide the measure of the added protection against the virus. These barriers do not, however, prevent the contamination of the equipment and the surface on the patient side of the barrier, which may then be touched by the staff and the patient and lead to the transmission. So hereby the homemade barriers may be more difficult to sterilize and could be the source of contaminations. In general, barriers are not substitute for the careful cleaning of the equipments. To further decrease the risk of any virus transmission, ophthalmologists should inform their patient that they will speak as little as possible during the slit lamp examination and request that the patient should refrain from the talking. So, ophthalmic point of view as an emergency, now we'll discuss the updated interim guidance of triage of the ophthalmic patients. Number 1 patients are those routine ophthalmic issues and previously scheduled appointments. Now we are discussing a very important topic, that is the how we can differentiate our patients into the sequence on the emergency point of view. So updated interim guidance for the triage of the ophthalmic patients. Number 1 category are those patients routine ophthalmic issues, and previously scheduled appointments. Routine problem should be deferred and previously scheduled appointment should be cancelled. Appointment should be rescheduled only upon the clearance from the local health authorities, such as directive from the district health authorities, CMO, and refill the all necessary medications. Second category of the patients in triage is urgent ophthalmology appointments for patients with no respiratory illness symptoms, no fever, and no COVID-19 risk factors. Standard precautions should be taken. The third category of the patients are the urgent ophthalmic problem in the patients with the respiratory illness, but no fever and other COVID-19 risk factors. Patient can be seen in the eye clinics. The patient should be placed in a examination lane immediately and asked to wear the surgical mask. And the treating ophthalmologist and the healthcare personnel require the surgical mask also. Gowns, glove and eye protection are recommended. N95 masks should be worn if the procedure is planned and that result in the aerosolized virus. The examination room must be clean after the examination. The fourth category is urgent ophthalmic problems in a patient who are at high risk of the COVID-19. Patient should be sent to the emergency room or the hospital-based facility equipped with the evaluation for and managing the COVID-19. If the patient has an urgent eye problem based on the screening questions, and the facility should be one that has equipped to provide the eye care in the hospital settings. If the SARS-CoV-2 infection is confirmed, then the hospital guidelines for the care of the suspected COPD should be followed for the healthcare facilities, preparation and infection controls. The eye care should be provided in the hospital setting. Precautions such as the treating ophthalmologist include the wearing the surgical mask, gown, gloves, and the eye protection, face shield or the goggles. Last part of triage is urgent ophthalmic problems in patients with documented COVID-19 or person having the investigation under investigations. Patient should remain in the hospital setting if possible. Determine whether the eye problem is urgent based on screening questions, or if so, evaluation and the management should be in the hospital settings. If the patient is not hospitalized at time of referral, patient should be referred to the emergency or the hospital-based facility equipped or to manage the both COVID-19 and the eye care. So we should refer to those settings where the both the facility for the treatment of the COVID-19 for medical as well as ophthalmic point of view, they must have the facility there. So now we'll discuss the standard universal precautions, minimum infection prevention precautions that apply to all patient care regardless of suspected or confirmed infection status of the patients. In any healthcare setting, hand hygiene, cough etiquettes, use of the personal protective equipments, cleaning and disinfecting environment surface. So currently there are the national and international shortage of the personal protective equipments, which is also warrant considerations. Excessive use of the PPE, personal protection equipment, may deplete the supply of the critical equipment required in the future for the patients with the COVID-19 as the epidemic expands. Use of the PPE should be considered on an institutional and case-by-case basis. Universal use of for the all patients in court is not appropriate. Transmission precautions. Second tier of the basic infection control used in addition to the standard precautions when the patients have disease that can spread through the contacts, droplets or airborne. Else for the outpatient clinics and the elective surgeries. In response to the state of the national emergency declared, guidance for outpatient clinics and elective surgeries. In response to these emergencies, ophthalmologists should seriously consider both intensity of the clinic scheduling and the issue of the elective surgeries, particularly elderly and those with the medical morbidities. Now we will discuss the outpatient clinics, OPDs. Ophthalmology offices should provide only urgent care make efforts to decompress their waiting areas, and consider the alternatives such as the encouraging patient to wait in other locations such as their cars and outdoor space. Mobile phone call or other approaches can be used by the office staff to notify the patients when they should come to the clinics. Now we will discuss the environmental, clinic and disinfection recommendations. Room and instrument should be thoroughly disinfected after each patient encounter. Wear the disposable gloves when cleaning and disinfecting surfaces, and discard the gloves after use. Street lamp, including control and accompanying breath shields, should be disinfected, particularly wherever patient put their hands and face. Diluted household bleach, 5 teaspoon bleach per gallon of the water. Second, alcohol solution with at least 70% alcohol, they should be used. Currently recommended for the use of the SARS CoV to include the Clorox based products, disinfecting wipes, multi-surface cleaning plus bleach and cleanup Kleenex and Lysol brand products. Lastly, tonometer tip cleaning. The virus causing COVID-19 is an enveloped virus, unlike adenovirus that are much more resistant to alcohol. If the tonometer tip is cleaned with alcohol and allowed to dry in room air, and 70% alcohol solution should be effective in disinfecting the tonometer tips from the SARS-CoV-2 virus. However, alcohol will not effectively sterilize the tip against the adenovirus. Use single-use disposable tonometer tips if available. Lastly, tips cleaned with the diluted bleach remain the safe and acceptable practice. I hope you might have enjoyed this video on current health issues. A lot of thanks for watching our video on coronavirus infection control and how to take care of ourselves and patients to prevent further infections. For any questions and more information, you are most welcome to ask any question in our comment box. We will feel happy to reply. Be safe and serve our noble profession with dedication and precautions. You are a hero who are saving the human lives. For more coming videos on health issues, organ donation and social awareness, please subscribe our channel for new updates. Thank you. Stay blessed.